Imagine you're examining a patient, right? You strike a tuning fork, you place it firmly on the mastoid bone behind their completely deaf right ear, and uh, they tell you they can hear it perfectly.
Which sounds completely impossible.
Right. Is it some medical miracle? No, it's an anatomical illusion. So if you're listening to this right now, maybe you're a medical student staring down a board exam, a resident prepping for rounds, or just a lifelong learner trying to decode the human head and neck.
And that head and neck anatomy is notoriously tricky.
Oh, absolutely. So today, we are jumping into a really high-yield text. It's called Multiple Choice Questions in Ear, Nose, and Throat by P.L. Dingra and Shruti Dingra. And our mission for this deep dive isn't just to, memorize a list of correct answers.
No, definitely not. It's about understanding the absolute physics and chemistry that dictate those answers. Because, understanding the underlying mechanism behind a fact is what actually allows you to treat a patient safely.
Right, because in the high-stakes world of medical training, obviously a single mark matters on a test, but
Out in the clinic, a millimeter of bone or, say, a microscopic nerve branch can completely change a patient's outcome. Your clinical reasoning has to be totally airtight.
Exactly. So let's actually start with something you probably see in the clinic every single day. Something most people just view as, like, debris, earwax, or cerumen.
Yeah, the classic nuisance.
Right. If you're just quickly reviewing notes before seeing a patient, you might assume it's just, dead skin and dirt. But the text describes cerumen as this highly engineered biological barrier. Like, mechanically, what is happening in the outer ear canal to produce this stuff?
Well, the production of cerumen relies on a very specific glandular ecosystem. So the outer ear canal has sebaceous glands, which produce lipid-rich sebum, and then it also has specialized apocrine glands.
Which are like modified sweat glands, right?
Exactly. And when those secretions mix with shed epithelial cells, they create this environment that is highly acidic.
Okay, so a low pH.
Right. And that low pH immediately makes the ear canal hostile to fungal and bacterial overgrowth. But even more than that, this fluid is exceptionally rich in an enzyme called lysozyme.
Lysozyme. Wait, doesn't that actually destroy bacteria?
It does. It's actively bactericidal. It literally cleaves the cell walls of invading bacteria.
Wow. Okay, so that reframes cerumen completely.
Oh.
It's essentially this acidic antibacterial moat protecting the eardrum.
That is a great way to think about it.
Which means aggressive cleaning with cotton swabs is actively destroying the patient's primary immune defense.
Yeah, you're stripping away a chemical barrier. And you're also disrupting the ear's, like, built-in escalator.
The escalator.
Yeah, the skin of the ear canal naturally migrates outwards over time. It carries the wax and the trapped debris with it.
Oh, that's wild. It just moves it out on its own.
Exactly. But if that self-cleansing mechanism fails, say the patient has a really narrow canal, and you absolutely must soften the wax, the text highlights using a 5% sodium bicarbonate solution.
Got it. So no harsh chemicals.
Right. It safely softens the hard wax without causing chemical burns to the delicate tissue underneath.
Okay, that makes the clinical approach a lot clearer.
Mm.
But while we're on the topic of cleaning the ear canal, the text details a bizarre clinical phenomenon.
The ear cough reflex.
Yes. You clean a patient's ear, and they suddenly start coughing.
Yeah.
Oh, I always assumed this was just a weird human glitch.
Mm-hmm.
But there has to be an anatomical reason for it, right?
There is. It all comes down to the brain's sensory mapping and the auricular branch of the vagus nerve.
That's cranial nerve X.
Right, cranial nerve X. This specific branch is sometimes called Arnold's nerve, and it supplies sensation to the ear canal. Now, the vagus nerve as a whole is massive. The vast majority of its sensory territory covers your respiratory tract, your lungs, your throat.
Okay. So the brain sensory map is basically overlapping, like crossed wires.
Basically, yeah.
It feels this physical stimulation in the ear from the cleaning instrument, but the real estate dedicated to the airway is just so massive that the brain just assumes the throat is being irritated.
That's exactly it. The brain misinterprets the origin of the signal. It gets the input at the brainstem and fires a defensive reflex to clear an airway that doesn't actually have anything in it.
That is amazing. The body is essentially tricking the clinician. And, if the anatomy can fool us with a simple cough, it forces me to wonder how diagnostic tests might also deceive us.
Oh, they definitely can.
Like that tuning fork illusion we talked about at the start. Let's unpack the false negative RIN test, because the RIN test is foundational for evaluating hearing loss.
It is. Normally, a positive RIN means air conduction is greater than bone conduction.
Right. But the text presents this scenario. A patient has a negative RIN test on the right ear. So bone conduction is perceived as louder than air conduction. Normally we think, okay, that's a conductive block in the right ear.
Right, like fluid or a fixed bone.
But then the Weber test, where you put the fork right on the middle of the forehead, it sends the sound laterally to the left ear. So how on earth can a deaf ear hear a tuning fork on its own mastoid bone?
Well, here's the trick. The right ear isn't experiencing conductive hearing loss at all. It has severe, profound sensorineural deafness.
So the nerve is shot.
Totally shot. The cochlea, or the auditory nerve on that right side, is completely dead. So the reason the patient raises their hand when you place the tuning fork on the right mastoid is due to the physical properties of the skull itself.
Because bone conducts sound.
Exactly. Bone is an excellent conductor. Those vibrations travel right through the entire cranium, totally bypassing the dead right side, and they stimulate the functioning cochlea on the left side.
Wow. So the dead right ear is essentially stealing the signal from the good left ear.
Yeah.
So the patient genuinely hears the sound. They just can't localize that it's actually processing on the completely opposite side of their head.
Which highlights the absolute vital importance of masking during audiometric testing.
Masking. Like playing static.
Yes. If you don't occupy the good ear with a masking noise, like a static hiss to keep it busy, a completely dead ear will masquerade as a simple conductive loss.
Oh man, so you might end up recommending a surgical intervention for a nerve that cannot even be salvaged.
Exactly. It's a massive diagnostic trap.
Misdirection seems to be the overarching theme here.
Yeah.
Not just in diagnostic illusions, but in the clinical terminology itself.
Oh, absolutely. The names can be very misleading.
Yeah, like if you're charting a patient's history and you see the word cholesteatoma, I mean, the oma suffix universally sounds like a tumor. It sounds like a cancer.
It's a terrifying term for a patient to hear, but the reality is that a cholesteatoma has absolutely zero neoplastic potential. It's not a benign tumor, and it's not a malignant tumor.
So what is it?
Put simply, it's skin in the wrong place.
Wait, just skin?
Just skin. It's stratified squamous epithelium trapped within the middle ear space, or the mastoid, and that's an area that's normally lined with respiratory mucosa.
So how does it get trapped?
Often it's drawn in by negative pressure from eustachian tube dysfunction, and once it's trapped in there, it just continues to shed dead keratin cells. But because the space is closed, that shedding keratin just accumulates into this expanding, tightly packed ball.
Okay, but if it's just a ball of dead skin cells, I struggle to see why the text treats it as a surgical emergency. I mean, how does dead skin become so incredibly dangerous?
The danger comes from the local biological response. The cholesteatoma matrix induces chronic inflammation, and this inflammatory state recruits osteoclasts.
Bone-eating cells.
Exactly. Osteoclasts and mononuclear cells. And these cells liberate really powerful proteolytic enzymes. We're talking proteases, collagenases, acid phosphatases.
Oh, wow. So it's not just a physical mass pushing on things. It's like a relentless enzyme factory.
Yes. It chemically erodes the temporal bone. So left unchecked, it will eat right through the delicate ossicles, destroying the patient's hearing.
Gee.
It can erode the facial nerve canal, causing facial paralysis. And worst case, it can eat straight through the roof of the middle ear into the cranial cavity.
Which leads to what? Brain infections.
Yeah, epidural abscesses or fatal meningitis.
From dead skin. A non-tumor that acts with the aggression of a cancer. That is wild. And, that misdirection brings up another terrifyingly named condition. Malignant otitis externa.
Right, another malignant misnomer.
Once again, the word implies a cancer.
It does, but the term malignant here strictly denotes the severity, the aggressiveness, and the high mortality rate of the infection if you leave it untreated.
Okay, so it's an infection.
Yes, it's a severe necrotizing infection of the ear canal, almost universally caused by the bacteria Pseudomonas aeruginosa.
Okay, Pseudomonas, we see that all the time with standard swimmer's ear.
Exactly, but this targets a very specific demographic. Elderly diabetic patients or severely immunocompromised individuals.
Right, so mechanically, what allows a simple swimmer's earbug to become malignant in an elderly diabetic patient?
Well, in that specific demographic, poor microcirculation and an impaired immune response allow the bacteria to invade much deeper. It doesn't just stay in the skin. It crosses the cartilaginous and bony junction of the ear canal and initiates osteomyelitis.
Bone infection.
A rampant infection of the bone itself, spreading right along the skull base.
And the skull base is incredibly danger countatory.
Oh, yeah.
I mean, the anatomical spread there has to involve the cranial nerves.
It does. As the infection sweeps along the base of the skull, it encounters the various foramina where the lower cranial nerves exit the brain, and it just sequentially knocks them out.
Wow.
Yeah. Cranial nerve IX goes, affecting swallowing. Cranial nerve X follows, paralyzing the vocal cords. Cranial nerve X impacts shoulder movement, and cranial nerve 12 causes paralysis of the tongue.
That is a chilling clinical picture. So if you see an elderly diabetic patient with like severe, unrelenting ear pain that gets worse at night, and they suddenly have difficulty swallowing,
You're likely looking at a rapidly progressing skull-base osteomyelitis. It's a huge emergency.
it really demonstrates how a localized issue in a confined space quickly becomes a neurological disaster. So let's look at another mechanical failure within the confined space of the ear, otosclerosis. We just talked about cholesteatomas dissolving the tiny bones of the middle ear. But in otosclerosis, the bones are perfectly intact, but they simply stop moving, right?
That's right. Otosclerosis is a localized disease of bone metabolism within the otic capsule. So abnormal spongy bone grows and eventually hardens, and it typically locks the footplate of the stapes bone right into the oval window.
And the stapes is supposed to act like a tiny piston.
Exactly, transmitting sound waves into the inner ear fluid. But when it fixates, that mechanical energy just cannot reach the inner ear, which results in a profound conductive hearing loss.
Now, the text highlights something called Carhart's notch as a primary diagnostic marker for this. Mechanically, how does a stiff bone in the middle ear cause an anomaly on a bone conduction test? I mean, bone conduction tests are supposed to bypass the middle ear entirely, right? Usually a dip in bone conduction means nerve damage.
Usually, yes, but the inner ear nerve is perfectly healthy in otosclerosis. The dip we see at the 2 kilohertz frequency on bone conduction, that's Carhart's notch, is purely a mechanical artifact.
An artifact. How so?
The stapes bone isn't just a passive transmitter. Its physical mobility actually contributes to the resonance of the entire inner ear system, specifically right around that 2 kilohertz mark. So when the stapes is locked in place, you lose that mechanical resonance. So the test shows an apparent sensorineural loss, but if you surgically mobilize the stapes, Carhart's notch completely disappears.
That is fascinating. The resonance of the bone itself dictates the test result. And the text also notes this weird symptom called paracusis willisii, where these patients actually report hearing better in noisy environments.
Which sounds completely counterintuitive.
It does, but if you deduce the human behavior behind it, it makes sense. A patient with otosclerosis has a built-in earplug, basically. So in a crowded restaurant, normal hearing people raise their voices to overcome the low-frequency background hum. The otosclerosis patient doesn't hear that background hum because of their conductive block, but they reap the benefit of everyone around them shouting.
Exactly. It's a brilliant paradox born from physics and social behavior. Now, to resolve the block, the treatment of choice is a stapedectomy.
Okay, walk me through that.
The locked stapes is surgically removed and replaced with a delicate prosthesis, which links the meniscus bone directly to the inner ear fluid.
Wait, if you're replacing the bone with a prosthesis, you're breaching the inner ear fluid space. There has to be a major structural vulnerability introduced there. I mean, you're essentially removing the natural pressure buffer, right?
You absolutely are. The vulnerability relates directly to Boyle's law and barometric pressure. This is exactly why a stapedectomy is strictly contraindicated for frequent air travelers, deep-sea divers, or heavy construction workers.
Oh, because of the pressure changes.
Right. An intact eardrum and normal acicular chain buffer those pressure changes. But post-stapedectomy, you've essentially plugged the parallel fluid space of the inner ear with a synthetic piston.
So extreme pressure changes could just pop it out.
Yes. Extreme pressure or severe straining can cause that fragile seal to rupture, creating a paralymph fistula.
So the inner ear fluid just leaks out into the middle ear. That has to be catastrophic for the patient's balance.
And their hearing. It induces profound, immediate vertigo. The room is violently spinning. And it can result in sudden, irreversible sensorineural hearing loss. I mean, a single deep dive could permanently end a commercial diver's career.
Wow. So physical pressure is a massive risk to the inner ear. But chemical pressure for medications is equally dangerous. The text dedicates a huge portion to ototoxicity.
It's a very common clinical issue.
We give patients drugs to heal them and inadvertently destroy their hearing. if you're prescribing these, how do you differentiate the damage profiles?
Well, you have to separate them into reversible and irreversible categories. So high-dose quinine, salicylates like aspirin, and loop diuretics like furosemide.
Like LASIK.
Right, those can cause sensorineural hearing loss and tinnitus. But the crucial clinical point here is that this toxicity alters the biochemical composition of the inner ear fluid temporarily.
Temporarily.
Yes. If you recognize the symptoms and withdraw the drug, the hearing typically recovers.
Okay, so stopping the loop diuretics reverses the tinnitus. But that implies there's another class of drugs where stopping them doesn't help at all, like where the structural damage to the cells is already done.
Unfortunately, yes, aminoglycoside antibiotics such as gentamicin and kanamycin cause permanent destruction.
Yeah.
These are powerful, life-saving 5V antibiotics used for severe infections, but they are highly toxic to the microscopic hair cells of the inner ear, and they don't damage the cochlea uniformly. They systematically target the outer hair cells of the basal turn of the cochlea first.
The basal turn. Okay, so if you map the cochlea, which is shaped like a snail shell, the base is physically tuned to perceive high-frequency sounds. So the patient loses high-frequency hearing first.
Exactly. And the loss is really insidious because human speech relies heavily on high-frequency consonants like the S, F, and the sounds to differentiate words.
So the patient isn't totally deaf, they just complain that everyone sounds like they're mumbling.
Right. And if you are not actively monitoring high-frequency audiograms while the patient is on the IV antibiotics, the damage will just progress from the base all the way to the apex and permanently wipe out all frequencies.
So if you're taking notes on this, definitely underline that.
Yeah.
Monitor the high frequencies when prescribing aminoglycosides. All right, let's transition from the microscopic confined spaces of the ear to the larger confined spaces of the airway. Because anatomy dictates that when a space is tight, a minor expansion becomes an emergency.
Absolutely.
Let's look at simple nasal polyps. They are super common in adults with allergies, but the text issues this massive red flag regarding pediatric patients.
A huge red flag. Simple inflammatory nasal polyps in a child under 5 years of age are incredibly rare. If you look into the nasal cavity of a toddler and see a grayish, grape-like mass, your clinical suspicion must immediately shift away from allergies.
It's like seeing a bulge in your ceiling and assuming it's just a minor water leak, but it's actually the floorboards of the room above giving way. Like, what is actually protruding into that child's nose?
In a young child, a unilateral nasal mass could be an encephalocele.
It's your brain tissue.
Actual brain tissue and meninges protruding through a congenital defect in the base of the skull. It could also be a nasal glioma.
Oh my God. So if a clinician assumes it's just an allergy polyp and decides to do a quick biopsy or, snare it in the clinic,
They are literally cutting into the patient's brain cavity.
that is a disaster.
It is. The result would be an immediate leak of cerebrospinal fluid, rapidly followed by a potentially fatal meningitis. That is why the text mandates that for any unilateral nasal mass in a young child, advanced imaging like a CT or MRI is absolutely mandatory to rule out an intracranial connection long before any instrument ever touches that mass.
That anatomical misdirection is just terrifying. And we see another example of confined spaces causing emergencies in the oral cavity. The text details Ludwig's angina.
How does a simple toothache, because it's usually an infected lower, second or third molar, right?
Yeah.
How does that turn into a life-threatening respiratory crisis?
It comes down to the unyielding fascial planes of the neck and the malahide muscle.
Okay, the muscle under the tongue.
Right, it forms the muscular sling of the floor of the mouth. Now, the roots of the lower second and third molars extend below the anatomical attachment of this mylohide sling. So when an abscess ruptures out of the tooth root, it enters the submandibular space.
And because the fascia below the jaw is tough and unyielding, the swelling can't just go down.
Exactly. It takes the path of least resistance, which is up.
The swelling expands upwards and backwards. It violently pushes the floor of the mouth up, and vitally, it forces the base of the tongue upwards and backwards directly against the posterior pharyngeal wall.
Oh, wow.
The patient presents with this woody, hard swelling under the chin. They're drooling because swallowing is totally impossible, and their airway is actively being crushed by their own tongue.
So securing that airway is the immediate priority.
Superseding even the treatment of the underlying infection. You have to save the airway first.
The anatomy literally forces the swelling to choke the patient. Man. Okay, moving further down the airway, we reach the larynx. We rely on our vocal cords as valves to protect the lungs, but also for the complex frequencies of human speech.
Right, our built-in instrument.
Yeah.
Yeah.
And the text outlines thyroplasty, which is a framework surgery where we fundamentally alter the cartilage of the larynx to change how the vocal cords function.
Yes, thyroplasty manipulates the vocal cords across 4 different types. So type I involves medial displacement. Let's say a paralyzed vocal cord is stuck open, causing a breathy voice and a risk of aspirating food.
Right.
Type I pushes that paralyzed cord towards the midline, so the functioning cord can actually meet it and close the gap.
Okay. And type 2?
Type 2 is lateral displacement. That's pulling paralyzed, closed cords apart to rescue a compromised airway.
Okay, so those first 2 are really about opening and closing the biological valve.
Yeah.
But types 3 and 4, those manipulate the frequency of the sound itself, right?
They do. Type 3 lowers the pitch of the voice by shortening or relaxing the tension on the vocal folds. And then type 4 aims to raise the pitch by lengthening and tightening the vocal cords.
Type 4 is literal physics applied to flesh. I mean, you're stretching the vocal folds tighter to increase the vibrational frequency, exactly like tightening a tuning peg on a guitar string, so the pitch goes up.
It really is. It's a profound surgical intervention, and it's frequently utilized in gender affirmation surgeries to align a patient's vocal frequency with their identity.
That is amazing. It perfectly illustrates that dense intersection of physics, biomechanics, and anatomy in the head and neck.
It really ties it all together.
Well, we have covered an incredible landscape of clinical knowledge today.
Yeah.
I mean, we reframed cerumen from simple dirt to this bactericidal immune barrier. We explored how the overlapping sensory map of the vagus nerve triggers a cough from just an ear cleaning.
And we unpacked the false negative RIN test, revealing how the skull's bone conduction can completely mask a dead nerve.
Right. We saw how a cholesteatoma chemically dissolves bone with enzymes, and how the mylohyoid sling forces a tooth abscess to crush an airway in Ludwig's angina.
You know, the overarching principle governing all these scenarios is this. In the head and neck, the symptom is rarely the source.
Say more about that.
An airway irritation might actually originate in the ear canal. A hearing response might be stolen from the opposite side of the skull. A simple nasal polyp might be the brain itself descending. The interconnected density of this anatomical region demands perpetual clinical vigilance. You just always must look one anatomical step beyond the immediate symptom.
Always look one step beyond. That is a perfect takeaway. So to make sure you are actively applying that principle, I want to leave you with a quick review exercise to puzzle over before your next study block or clinical shift. Based on the mechanical and structural concepts we explored today, if a patient presents to your clinic complaining of a roaring low-frequency tinnitus versus a patient who complains of a pulsatile tinnitus, like a rhythmic heartbeat in their ear, what entirely different underlying physiological mechanism should instantly pop into your differential diagnosis?
Think about the inner ear fluid pressures causing Meniere's disease versus the highly vascular anatomical nature of glomus tumors.
Exactly. Keep questioning those physiological connections and never stop looking for the why behind the symptom. Thanks for joining us on this deep dive. Keep learning, and we'll catch you next time.